Thank you once again. I hope you can hear me well. And I would like to thank Dr. Hung in the background who's helping me with that translation. So thank you. Thank you once again for my friends in Vietnam to invite me again. I'm very grateful that I'm here. So today I'm going to talk to you about what I understand when I see a patient with Guillain-Barré syndrome. What are the diseases that can look like Guillain-Barré syndrome, and therefore what are the considerations that you would have as a clinician. Now, if you were to scan this QR code, you can download my notes. I'll show this at the end of the lecture again. Dr. Hung, the speed is okay? Okay, great. Okay, so this is a typical Guillain-Barré syndrome. So a patient comes to you with acute flaccid weakness and sensory loss. Often the symptoms start from the lower limbs and ascend upwards. Very characteristically, these patients have cranial neuropathies like oculomotor dysfunction, you can see in this picture, swallowing and speech problems, and autonomic dysfunction. Autonomic dysfunction. So you notice that it's a very characteristic feature. Acute weakness of all four limbs, ascending upwards very quickly over a period of 2 to 3 weeks. In fact, we often take the timeline of 3 weeks. Very distinctively, for a peripheral neuropathy, it involves lots of cranial nerves. In fact, all cranial nerves can be involved except the first and the second, because the first and the second are part of the central nervous system, right? So patients can develop ophthalmoplegia, facial weakness, swallowing problems, speech problems. Very characteristically, it is the most important peripheral neuropathy that causes acute autonomic dysfunction. So you notice that all the features are so characteristic that almost all of you in the audience will know how to recognize Guillain-Barré syndrome because the features are very, very characteristic. So let me share with you about this patient. I saw this young girl in a town called Peshawar, which is the northern part of Pakistan, bordering Afghanistan. She's actually an Afghani girl who came from the hills to the hospital because there were no hospitals in that part of Afghanistan. She was seen by the pediatricians for a complaint of acute sore throat, and she was treated with antibiotics. Being a hospital in a poor country, in a poor region, there were no resources to find out what was the organism. Most times when they see an infection in the throat, they give penicillin and the patients get better. But then subsequently, she was referred to us, the neuromuscular adult physicians. Pediatricians referred us because 2 to 3 weeks later, she developed weakness in the limbs that was ascending upwards. She had swallowing problems and speech problems. So again, just like I said earlier, very characteristic features of Guillain-Barré syndrome, right? An infection, and then sometime after the infection, patient develops acute weakness, ascending, sensory complaints may or may not be there. In this case, she was too young for us to be sure whether she had numbness. She had significant weakness and sensory loss with loss of reflexes. So very characteristic, right? You agree? So I told my resident, my Pakistani resident who was helping me translate, I said, when something looks like a duck, walks like a duck, flies like a duck, quacks like a duck, and you know, we all like to eat duck, tastes like a duck, it's a duck. So I said, the key features of this patient resembles Guillain-Barré syndrome, Because in Guillain-Barré syndrome, you get an infection, then you have ascending weakness, you have ascending sensory loss, you have cranial neuropathies. So what is there to argue? This patient must have Guillain-Barré syndrome. But then this resident pulled me aside and whispered to me, doctor. Then I said, what? He said, could this be a goose? Then I said, I thought he was joking. But actually, in parts of Afghanistan, vaccination against common infection that we give to all our children is not uniform. So measles and diphtheria was a common infection in children because these children are not properly vaccinated. So he asked me whether this patient is not a duck, but a goose, which is diphtheric peripheral neuropathy. Now, at this point, I was very nervous because I've not seen, in my practice, before I saw this girl, I've never seen a case of diphtheria, let alone diphtheric neuropathy. But I remembered that one of the key signs in diphtheric neuropathy is the inverse Agar-Robertson people. So we all know in Agar-Robertson people, the patient's pupils respond poorly to light, but very well to convergence and accommodation. But in diphtheric neuropathy, one key feature is the opposite. It responds very well to light, but the patients cannot read because they can't constrict their pupils to convergence. So this lady had that, and that helped us confirm that hers is not Guillain-Barré syndrome, but a mimic of Guillain-Barré syndrome, which is common in this part of the world, not in our countries, but in poor countries like Afghanistan and northern Pakistan, diphtheric neuropathy. Another lesson I learned when I was in Zambia was this lady, also with diphtheric neuropathy. Very interestingly, she came to us with a story that she was diagnosed with HIV. She was started on HIV drugs. You know, in Africa, HIV drugs is free, so she was started on HIV drugs. And then 6 months after that, she developed very severe sore throat. And she was seen in a small hospital, and penicillin was given. And she said the sore throat was so severe that she couldn't swallow. So then I thought, this must be just bad sore throat, painful. But she said, no, doctor, it was painful, but I couldn't swallow because I just couldn't get my water into my throat. I had loss of voice and fluid was coming out through my nose, and the doctors had to feed me with a tube. So she developed bulbar weakness at the time of throat infection. And she also complained of numbness around the lips. Now, this is something that when I went back to the outbreaks of diphtheria, for example, in the 1990s, there was an outbreak of diphtheria in Russia. And very nice cases came out about what diphtheric neuropathy looks like. One of the key features is there's a lot of neurological symptoms around the primary infection. The throat infection causes weakness of bulbar muscles and may even cause local cranial neuropathy. But very interestingly, this girl will report, and this is also mentioned in the Russian series, when you're given antibiotics, the infection clears, the patient recovers from the throat infection and the bulbar weakness. She went home. She started work as a secretary. 2 to 3 weeks later, after recovering from the initial neurological problem, she came to us with ascending weakness. This is what I refer to as the biphasic cause. 2 phases. Initially, bulbar weakness, recovers, and second, this is again very characteristic of diphtheric neuropathy, but never seen in Guillain-Barré syndrome because Guillain-Barré syndrome is almost always a monophasic illness. Okay? And just like the earlier patient, she had very nice pupillary abnormalities that allowed us to confirm that she had diphtheric neuropathy. So, one of the mimics of Guillain-Barré syndrome is diphtheria. Now, this is another patient. I didn't see this patient myself. It was shared with me by one of my good friends from India. He's Professor Satish Kadilkar. He's a very famous professor in India, and he told me about this case, and I was very interested, so I took his notes, and I want to present the story. They saw this patient. He's a very experienced professor. He saw a patient with ascending weakness, a young boy, with a lot of signs and symptoms of Guillain-Barré syndrome. So just like what I said earlier, it looks like a duck, walks like a duck, quacks like a duck. They thought it was a duck. Even though there were some features like the CSF cells were slightly high. But they thought it was Guillain-Barré syndrome. So they admitted the patient to ICU, started the patient on immunoglobulins. But then the next day, he started getting he started developing lots of fasciculations, hyperhidrosis, and hydrophobia. He couldn't drink any water. And then when they took the history, the parents reported that a few weeks ago, the boy had a dog bite. A street dog bit him. So this is the first time I've seen a case of a pure paralytic form of rabies. Now, this patient that I saw in Ghana has got the classic form of rabies, which is encephalopathic. I think all of us are familiar with that. But this case told me that some patients, about 20% of rabies patients, before they get the encephalopathy, they come to you with ascending weakness, and this is known as the pure paralytic form. Again, important mimic of GBS in developing countries. So I realized that in poor countries, not everything that paralyzes is Guillain-Barré syndrome. We have to still think about infectious disease and other diseases that the developed parts of the world have forgotten about because of improvement in public health and vaccination. Likewise, this is a patient. Of course, this is nothing to do with the poor country. You will see this in all parts of the world. I saw this man maybe about 10 years ago. He was incarcerated. He was in the prison because he was a drug addict. And one of the things, he went into severe depression. And because of the depression, he had a lot of issues in the prison. But he came to us for ascending weakness, numbness, hoarseness of voice, and urinary retention. Again, acute weakness with sensory loss, bulbar symptoms, hoarseness of voice, and autonomic symptoms. So looks like a duck, walks like a duck, quacks like a duck. So I thought it was Guillain-Barré syndrome. Very interestingly, I was telling the wife, about how he had Guillain-Barré syndrome, and, he will be better in 3 weeks' time. At that time, the wife said, "Oh, that's interesting, doctor." And then I told the wife that, the patient is very upset that he can't go to work. He can't go back to work as a manager. Then the lady told me, that's interesting, doctor, because my husband hasn't been working for the last 10 years, and he has just been drinking alcohol, after coming out of prison, and he hasn't been to work at all. What work is he talking about? And that's the point when I realized that he was actually confabulating. He was confabulating that he was working because he didn't have Guillain-Barré syndrome. He had Wernicke's encephalopathy with beriberi neuropathy. So, one of the things that you must always remember in patients who are drinking a lot, patients on chemotherapy, patients with hyperemesis gravidarum who are vomiting a lot, these patients may have a thiamine deficiency. Very interestingly, thiamine deficiency will present predominantly with brain symptoms, encephalopathy, confusion, confabulation, lying about his job, that kind of story. But occasionally we see what we call dry beriberi. Patients who present predominantly with weakness of the limbs And if you look carefully at them, there is only subtle central nervous system features. So we went back to look at our series of patients. So we had quite a number of patients who had beriberi neuropathy that were initially misdiagnosed as Guillain-Barré syndrome, just like this patient, okay? And obviously, it's important not to misdiagnose it because in these patients, you need to give them large amounts of intravenous thiamine. And if we delay this, they develop permanent central nervous system injury. So it's important to recognize that. So we went back to look at our patients and ask, is there something in the presentation that will make you think? Number one is, of course, the history of poor eating, the history of alcohol consumption, excessive amounts of alcohol consumption, the history of vomiting. One patient also had thyrotoxicosis plus vomiting. You know, the patient's metabolic demand was very high, so went into Wernicke's and beriberi neuropathy. The other important feature is that even though they may not have much confusion, look carefully for eye signs like nystagmus. Okay, and when you are doing the bloods, you'll be surprised that even though they don't have septicemia, the serum lactate will be disproportionately high. So this is another clue. This clue should make you quickly give this patient thiamine. If your laboratory can do the thiamine levels, that's good. But even if you can't do it, you should give these patients thiamine because, as you know, thiamine is a harmless drug. And if you give it to the wrong patient, there's no harm to the patient. But if you miss giving it to the right patient, then the consequences are permanent. The permanent loss of memory. And of course, their neuropathy can also be very, very severe. So another mimic of Guillain-Barré syndrome in developing and developed countries is beriberi neuropathy. So please look out for it because I think just like in Singapore, Vietnamese like to drink quite a lot. And sometimes they drink a lot, but they don't eat enough balanced diet. Okay? Another interesting patient that I initially thought had Guillain-Barré syndrome. Very interesting story. He was a diabetic man, young man. He came to us after an infection, a diarrheal infection. After developing a diarrheal infection, he developed ascending weakness and sensory loss. Ascending weakness and sensory loss. So, and he also had a lot of autonomic dysfunction. So again, infection, followed by ascending weakness and numbness, lots of autonomic symptoms, looks like a duck, walks like a duck, quacks like a duck, tastes like a duck. So I thought it was a duck. So we did the spinal tap. The spinal tap protein was very high. We were very sure this was a duck. We did the nerve conduction study. It showed some changes consistent with the neuropathy. We were even more sure that this was a duck. So we started the patient on IVIG. But after 3 weeks, after 4 weeks, he continued to have symptoms, progressive symptoms. And his symptoms were mostly not so much weakness, but a lot of small fiber symptoms, pain, paresthesias, allodynia, hyperalgesia. His legs were burning all the time, and he was very disturbed by this pain. And it wasn't getting better, it was getting worse. And he had severe erectile dysfunction. For a 34-year-old man, he had absolutely no ability to participate in sexual activity, complete erectile dysfunction. In addition, he had severe postural hypotension and urinary symptoms. So severe dysautonomia together with painful neuropathy. At this point, they called us again, the hospital doctors, and said, your patient is not well at all. Can you come and review the patient again? And that's when we diagnosed, that was when we realized that actually this patient was diagnosed with diabetes just a few months ago. At that time, his HbA1c was 12.8. And because he was a young man, he was very upset. He was very upset that he has developed diabetes. So he went into a severe diet. He didn't eat very much, and his blood sugars went down from 12 to 7. During this period, he developed acute autonomic symptoms. And one of his autonomic symptoms was actually the diarrhea, which initially we thought was an infective diarrhea, but actually it wasn't. It was nocturnal diarrhea from autonomic symptoms. So he did not have Guillain-Barré syndrome. He actually had treatment-induced neuropathy of diabetes. In the old literature, we used to call it insulin neuritis. So this is typically seen in insulin-dependent patients, but it can also be seen in patients on oral hypoglycemic agents. What happens is, after a 2 to 3 month period of sudden improvement in glycemic control, it has to be very sudden. Remember, this man, from 12, he went to 7 in 3 months. Has to be very sudden. Often associated with poor diet. They are not eating well. They are losing weight. When you put these two together, they develop 3 things. Severe small fiber neuropathy, severe autonomic dysfunction, and severe maculopathy. And the maculopathy can make them blind. So when we quickly brought him to the eye doctors, we checked his macula, and his macula was also swollen. So this patient had all the features of treatment-induced neuropathy of diabetes. And that's beautifully summarized in this paper, so I'm going to read to you. There is an unexpected high proportion of individuals with TIND in tertiary diabetic centers because of their emphasis on very tight blood sugar control. The risk of developing TIND is associated with the magnitude and the rate of change. So both the amount of change and the speed at which it comes down is very important. Okay? And it's characterized by severe small fiber neuropathic pain and autonomic dysfunction, associated also with maculopathy. Most commonly seen in insulin patients, but it can also be seen in patients taking oral hypoglycemic agents. So, please remember this as another mimic of Guillain-Barré syndrome. Another case that again was shared with me by Professor Satish Kadilka from India. So this is another patient, a young man, again came with acute onset of diarrhea, but 3 to 4 days later, he developed quadriparesis and loss of sensation. Again, looks like a duck, walks like a duck, quacks like a duck, but unusually he became also very confused. And within 3 weeks, he developed complete loss of his hair. He became from a full-haired person to a bald person. And he developed Mees lines, M-E-E-S, Mees lines. Can you see these lines here? Okay, so what do you think he was poisoned with? He was actually a loan shark, you know, the person who gives out loans. So one of the persons who didn't want to pay him back decides to put thallium into his food over a period of time. And this man developed acute thallium toxicity, which can present with acute peripheral and autonomic neuropathy. And of course, this famous case, this Russian agent, you all may know of it, was also poisoned in the same way. This is when he was a normal person. This is when he was diagnosed with thallium poisoning in a British hospital after many years of surreptitiously poisoning his food with thallium. So, in summary, I have given you some of the common cases of diseases that look like Guillain-Barré syndrome. So, it looked like a duck, walked like a duck, quacked like a duck, but it wasn't really a duck. But in all honesty, the mimics of Guillain-Barré syndrome is not common. Because most of the time, if you see a patient with acute paralysis, acute ascending weakness, acute sensory loss, with cranial neuropathy, autonomic dysfunction, with preceding infection, you are most likely dealing with Guillain-Barré syndrome. So, if you are wrong, it is only a small group of patients. How small? Well, what we did was, we went back for about 10 years and looked at our series of Guillain-Barré syndrome patients. And looked at all those patients that initially we thought was Guillain-Barré syndrome, but turned out to be not Guillain-Barré syndrome. This is in the context of Singapore. So what was the commonest disease we found? Beriberi and Wernicke's encephalopathy. Beriberi neuropathy was the commonest. And even that was only about 5 cases. Only 5 cases over a period of 10 years. So the majority of the patients that we thought was Guillain-Barré syndrome was indeed Guillain-Barré syndrome. So don't become too paranoid about mimics. Okay? Most times when a good neurologist thinks it's Guillain-Barré syndrome, you're right. Okay? But if you're wrong, what is the most common in our countries? Well, it's Wernicke's and beriberi neuropathy. The other conditions, sensory neuronopathy. Dr. Say had one patient like that recently. Vasculitic neuropathy, porphyria, treatment-induced neuropathy of diabetes, the patient I showed you. Okay? And then a few other conditions. They are all 1 or 2 cases only. Then, of course, in my travels, when I work in other countries, in poor countries, I did see patients with diphtheria. I did see patients with poisoning from environmental toxins. I saw patients with encephalitic, non-encephalitic paralytic form of rabies. But that's only in developing countries, right? So in countries like Vietnam and Singapore, I think the most important mimic would be Wernicke's encephalopathy. Finally, I'm going to finish off with the chameleons. What are chameleons? Well, all these animals are the same animals, right? All these pictures. But they have different morphology, right? Different colors and shape. So Guillain-Barré syndrome also has got different colors and shape. So we have to remember that Guillain-Barré syndrome doesn't have only one form. It has many forms. So, like this man who came to us, he's a 54-year-old man, a piano teacher. I'm not sure why he's still staying with his parents, but that's another story. Okay, one morning he woke up with acute drooping of his eyelids with numbness of the hands. He was seen in the emergency department. They thought his numbness of the hand was due to maybe diabetes, wrongly diagnosed him as not a serious condition, sent him home. But on the same day, he developed dysarthria and dysphagia. Okay? Same day, he developed dysarthria and dysphagia. So mild ocular symptoms, then within a few hours, dysarthria, dysphagia. He came back to the hospital. Now, in emergency departments, most times when somebody comes with an acute neurological problem, without even examining, the emergency doctors often assume it's a stroke. So they said it's a stroke. Did a scan. The scan was negative, but they said that's a neurologist problem. But my neurologist, my colleague neurologist who was in the emergency department, was very careful, went back to examine and found that he had a number of cranial neuropathies. You can see he had a number of cranial neuropathies. He also had areflexia, no reflexes in his limb, even though he was only recently diagnosed with diabetes. And he had mild proximal weakness. So, because there was not much sensory loss, he thought that this patient could have a myasthenic problem, but it came very acutely. So, not likely myasthenia. But what about multiple cranial neuropathies? So, I think the students in the audience know that whenever I teach you, I use a formula for cranial neuropathies. So, any cranial neuropathies, we use these 4 formulas, 4 questions, you will get the right answer, correct? So, in this case, the presence of areflexia and proximal weakness made my registrar, my junior colleague who was in the emergency department, think that these cranial neuropathies must be due to Guillain-Barré syndrome, what I call the rule number 4. There are 4 rules there, rule number 4, okay? So with that, she went ahead to do the nerve conduction study. It didn't show any decremental response, but it showed the characteristic sural sparing. We all know sural sparing is a very useful tool to diagnose Guillain-Barré syndrome and also to rule out the mimics, because most of the mimics I told you about, whether it's diphtheric neuropathy, rabies, whether it's beriberi neuropathy, porphyria, they don't have the sural sparing pattern. So the sural sparing pattern, if it's present, is very helpful to confirm your suspicion that it's Guillain-Barré syndrome. And then, of course, subsequently, the patient developed more weakness, and it became clear with the antibody testing that he had an unusual form of Guillain-Barré syndrome, which is the pharyngeobrachial cervical variant. Not a common form of Guillain-Barré syndrome. It's one of the unusual forms of the chameleon. Of course, another uncommon form that we see more commonly in Asian countries is the Miller-Fisher form of Guillain-Barré syndrome, where the patient doesn't have weakness, but has ophthalmoplegia, ataxia, and areflexia. That's more common in our countries. And occasionally, Guillain-Barré syndrome can come with encephalopathy too. When it comes with encephalopathy, when the patients are drowsy, always think about Wernicke's. But don't forget, there is also a form of Guillain-Barré syndrome called Bickerstaff encephalitis, and that should be treated with immunoglobulin because it is just another form of Guillain-Barré syndrome with central nervous system features. And before we forget, we must remember that sometimes CIDP can present very acutely and trick us into thinking it's Guillain-Barré syndrome. The key feature is progression of symptoms beyond 4 weeks. If the patients develop more weakness, more sensory complaints after 4 weeks, then you have to start thinking about Guillain-Barré syndrome. But in a few cases, I got the diagnosis wrong because these patients had predominantly axonal features. Now, we know that CIDP is a demyelinating disease. So when we see an axonal GBS, normally we don't have to think about, I thought we don't have to think about acute onset CIDP, correct? That's what I thought, until I saw this patient who was contactin antibody positive paranodal antibody, CIDP. So in this particular group of patients, they present to you like GBS. Acutely, the demyelinating features may not be very prominent. They may have a lot of axonal features. But the key feature is, that besides the acute onset, they have axonal features. The key feature is they don't respond to immunoglobulins. So if your GBS patients continue to progress, we have to think about CIDP. But even if they have axonal features, remember there is some form of CIDP where the axonal features are more common than the demyelinating features. And that's when you have to start thinking about contactin antibody positive CIDP and send the antibody testing to the relevant laboratories, confirm the diagnosis, and these patients will respond better to rituximab. They don't respond well to steroids or IVIG, they won't respond to it. Because I don't have much time to talk about paranodal CIDP and explain to you with my case references, but I've given you this QR code, you can look it up. And I did give the same talk last year on paranodal CIDP. So in summary, most of us, when we see a patient after an infection developing acute ascending weakness and sensory loss with loss of reflexes, cranial neuropathies and autonomic symptoms, it is going to be a duck. It's going to be Guillain-Barré syndrome. But do remember some mimics. For example, beriberi neuropathy. For example, treatment-induced neuropathy of diabetes, sensory neuropathies, sensory neuronopathies, vasculitic neuropathies, but they are very rare. Okay? And then also the acute form of CIDPs. And if you are working in developing parts of the world where diphtheria is common, rabies is common, and some of the environmental toxins, poisons that come from the environment, or in fact sometimes it's forensic poisons, then you have to start thinking about the other mimics of GBS. And then of course don't forget that GBS doesn't have only one shape, it has got many shapes, and that's why Dr. Nia chose the topic GBS and the chameleons. Just like a chameleon, they're all the same animal but got different shapes. Thank you.